the muscle athletically?
I don't really think so. So when you do this repair, the muscles are all relaxed. The patient's given medications that the muscle are relaxed. And I think that there is probably some artistic level of input here where you're pulling them together so that they're in the right position and that you're still getting a nice cosmetic result versus just pulling them as tight as you can. Because as tight as you can is not the right answer. And as tight as you can when you take out the skin is not the right answer too. I mean, I hear stories all the time that somebody was closed so tight that it took 3 weeks before they could stand up straight again. And that's too tight. Besides, a normal female body doesn't look like that. We're a little bit fuller below. So then again, this is part of the relationship with your surgeon. I will say you are not going to be bored flat because nobody is bored flat.
Right.
Go get your Victoria's Secret, magazine and look at even these very, very thin women have a little fullness below. So what you want to look like is good and healthy and normal. Right. And I want you standing up inside of a week. I am never going to make you so tight that you can't stand up inside of a week. So if you come back to see me at a week, and you will have already seen me twice to have the drains taken out, right? If you come back and see me at a week and you're not standing up straight, I'm going to say stand up because you're not going to unzip. I know you might still feel tight, but you need to stand up and unload your back and start getting back to moving your body properly.
Okay, cool. Let's see. So we've got, muscle function. Okay, cool.
Recovery.
Now, have you ever, one more thing before recovery, belly button. So this is always a hot topic about, I was weird in the fact that I was not super concerned. I was just so nervous about being okay functionally. And I knew my surgeon was really good. So I was like, I just thought it would look fine. And I really did trust him. But I know the belly button is a big deal and people do it in different ways. And a couple of surgeons told me I'd have to lose my belly button. They have to make me a new one because I was all, But then my surgeon was like, no, we can keep your belly button. I was like, cool. So what's your belly button take? And then we'll talk recovery.
So first of all, belly buttons all look different from each other. And I also using Victoria's Secret, I don't even know if they have a catalog anymore, but I went through Victoria's Secret for a while looking at belly buttons and they're all different shapes.
Yeah.
And when I was in training, I was taught to make a circle. Some people made like a upside down smile and to just kind of put the belly button up there. And again, when we talk about surface contours of the abdominal wall, an unoperated belly button doesn't sit flat up there on the surface of the abdominal wall. So if it's just flat with a hole in the middle, it doesn't matter what shape that hole is, the belly button doesn't look right. So I try to maintain the belly button whenever I can. Sometimes they will have had previous surgeries in there, or that the belly button is just like so stretched out that I just don't have enough to work with. And then I will recreate a dimple in that area, and it involves making a couple of little flaps and tucking one up and doing this. But the most important thing I think we do at the belly button is to recognize that a normal belly button is kind of at the center of a little bit of a circumferential dip. So treating the abdominal wall so that you're defatting it, so that it's really pulling down, because it gives you a much more normal looking belly button. It also can bring the incision underneath the surface of the abdominal wall so you don't have a scar there. So it's all about contouring and about where you put your incisions, so that, because the belly button itself is a dimple, right? It's where your umbilical cord used to go all the way through your abdominal wall. So you have no abdominal wall elements in that area, and it went into your abdomen and up to your liver. And after birth, when you don't need it anymore, that hole heals, but the fat doesn't creep, the subcutaneous fat doesn't creep across. So you have a dimple there, and we just leave that dimple, and we want that dimple to still dimple on the abdominal wall. Does that make sense?
Yeah. So
Okay.
So now what about umbilical hernias? Do you also repair those? Do you bring it in?
So I don't bring in a general surgeon
Okay.
for those because I am a general surgeon. So
Cool.
I did my full general surgery training and was board certified in general surgery. I don't do them for insurance, but I also explain, I explain to patients why I also don't charge them more. It may take a little bit longer in the operating room, but I'm fully capable of doing an umbilical hernia repair. What I don't like is when the general surgeons are coming in and doing a laparoscopic repair and putting a plug in the umbilicus. And I just, an umbilical hernia repair is a tiny little operation. It's a little slick operation. And my concern about this other way of doing it is that an abdominoplasty is not inside your abdomen. It's not inside your peritoneal cavity. And the umbilical hernia repair done through what we call an open approach, like when you're doing a tummy tuck, is done also outside of the abdomen, right? When you start doing a laparoscopic operation and you're putting these pieces of equipment into the peritoneal cavity, you then have another whole list of long-term risks from having violated the abdominal cavity.
Okay.
And it's just not necessary.
Okay.
So I will sometimes, on heavier patients, I'll uncover hernias that we didn't even know were there, and I repair those. So I fix the umbilical hernias the same.
Yes. I think that's really great info for people, because I know and the other couple people I interviewed, I had them speak on the endoscopic or laparoscopic repairs for the diastasis.
Yeah.
And they were just saying, well, it doesn't go all the way up. It's not done the same way. I think sometimes,
and there are two
can cover that. So people try to slide in, but then I want them to understand it's not the same procedure.
And there are two different things that we're talking about. There are two different versions of what might be referred to as laparoscopic rectus diastasis repair.
Okay.
One of them is done by some plastic surgeons where you actually don't go into the abdomen, but instead of doing the whole dissection all the way up to the ribs, in the upper portion of the abdomen, they just make a little tunnel and they use a camera and they do a repair through a very small incision using the camera. That is still an external rectus diastasis repair.
Okay.
But it's being done through smaller incisions, and there are pros and cons to that. Okay. And that would be done most commonly if you were somebody who had so little skin that you really only need a mini tummy tuck, which only involves operating on a skin basis up to the belly button. But you still have some rectus diastasis above and you want to repair that. And I want to tell you that happens in almost nobody.
Yeah.
So we would have to really like doing that operation to try to find a patient for whom that would be the right operation. Right. Okay. The other thing, and I think it's important to make this distinction, is what the general surgeons do.
Okay.
Which is, I think, what you're talking about, which is a laparoscopic rectus diastasis repair, which is not a diastasis repair at all. No. What they are doing is going in there, and from the underside of the abdominal wall, they are stapling a piece of mesh to span the diastasis. They are not narrowing the diastasis. They are just like reinforcing that stretched out fascia. And it is not a diastasis repair at all.
Wow. Oh.
And it is at least this is in my experience. Okay, I will say that when I finished general surgery training in '92, we had just started doing laparoscopic gallbladders. We were not doing any of this. But I have seen patients back in my office, and I've gotten the operative reports. And I've seen that, at least in my area, the surgeons are just smacking a piece of mesh up there. That doesn't pull the muscles back together. They're completely missing the problem. And in my opinion, they're making a external to the peritoneal cavity operation, a transperitoneal cavity operation, and they're still not correcting what needs to be corrected.
Right.
It's a problem.
Right. I've also found that's so helpful. Thank you.
Sure.
The hernia repair that you explained was also very helpful, because the umbilical hernias are tricky, because sometimes, I understand sometimes it's an emergency and you have to get it fixed for whatever reason, right? But in a lot of times, you know, women are done having kids yet, they have this umbilical hernia fix that maybe they could have just waited, and then they have this mesh in there, and then
and the mesh hurts.
Oh my gosh.
And the tissues are thinned out.
Abdominoplasty, but then you got all this mesh, and it breaks my heart. Now, again, sometimes I know you can't wait on the hernia depending on how it is, because it can be a medical emergency. But in a lot of ways, yeah. And then what you explained with the other kind of repairs, oh my gosh, like.
Yeah, they don't need to be putting that mesh in there. And, you know, it's interesting because, again, I was lucky enough to be in general surgery training as laparoscopic surgery actually started.
Oh.
So it was a very exciting time, but we all trained to do operations open, right? So much is being done laparoscopically now that there are surgeons out there in practice who've just never done an open one.
Yeah.
And it, you know, it's an interesting thing. When I needed my gallbladder taken out, you know, my husband, who's an anesthesiologist, chose the surgeon who was old enough to remember how to do an open gallbladder in case something happened where he needed to open, because the training has changed and the techniques have changed. And but hernia repair, the umbilical hernia repair, is such a simple operation externally that it's really like the tail wagging the dog to do it trans-abdominally, laparoscopically. I don't get it. I mean, I do get it, but I don't think it's right.
Yeah. Good.
So,
love it. Yeah. Okay. Well, don't love that, but I'm just good.
No, I understand. I got it. Thank you.
I want people to know.
Yeah.
Everything out there as much as we can. Okay, great. So we hit the hernia stuff. We hit belly button. Okay, so recovery. So you talked about things already. Great, because that was on my list. One of the first things to ask about that. Now, risks with seromas and hematomas.
Yeah. The risks are relatively low. Okay. I have done, I don't know how many abdominoplasties. I had one patient with a hematoma who ended up back in the hospital because by the time the answering service got me on the phone, she had already called the ambulance. And she said to me, she was hospitalized, but she was not operated on again. Once she was stabilized, she was sent home and came back to me, and I was able to drain the hematoma in the office. Oh. You know, we opened the incision and it drained, and then she had an area of secondary, healing. But she said to me, I bled when I had my hysterectomy too. And I said, and where in that questionnaire where we said, have you ever had any problems with bleeding? Did you not think? She said, really, you think I should? I said, yes. If you ever have another surgery, please make sure you tell the surgeon that you have had 2 post-surgical bleeds. Okay. And seroma, I've had one patient who had a seroma that was, really pesky, and it took a while for it to go away, but she was treated conservatively, in the office, and it did go away. So it's relatively low incidence in my practice. I will say that, these seromas are issues of healing. And one of the things that I discovered early on is that a majority of our American women patients are pretty malnourished because we're always dieting and we're always starving ourselves, and we may exist on the leftovers, from on our kids' plates, and then we ate all that leftover grilled cheese, and we don't give ourselves a proper dinner. So I learned this because I had a patient who was in excellent shape and a big CrossFit, and she came in, and at about a week, at her visit at a week, we changed the steri strips on the incision, and the whole incision was open. Wow. I mean, it had not healed. And lack of healing occurs for 2 basic reasons. One is infection, and the other is nutrition. And as a general surgeon, we learned all about surgical nutrition, but we don't necessarily apply it when